So good afternoon, everyone. What I'd like to start by saying is I really don't want to give a didactic lecture. I'd rather this be interactive, so please stop me, ask me questions along the way. Unfortunately for you, there are about 20 slides that are, can you spot the problem? And you're each going to get a turn to describe what you can see, and then we can see if we can figure it out. So I thought that was the best way. I'd rather teach you things that way. It's more practical, it's more proactive, it keeps you engaged rather than me standing here and talking for 30 minutes. I'd prefer not to do that. But to start with, we are going to do a little bit of an overview just so that we have the background. I could obviously show you the slides but not give you any information and do that afterwards, but I think it's fair for me to educate you and then see what you've learned. Okay, so we're going to start with some basics. If I can get to advance. There we go. Okay, some basic ocular anatomy. We're going to start with the easy stuff. Anyone want to volunteer what structure A is over there? It's that blue structure. So it's a cross-section or sort of a wedge cut out of an eye. Anyone know what A is? The iris. Okay, great. B is this clear transparent layer that's continuous with the white part, the cornea. Sorry if I'm insulting your intelligence, but it's... C is this black appearing hole in the middle, the pupil. Okay. D is this clear structure that's behind the pupil, the lens. E is this little muscular structure here that's actually holds the lens in position. Anyone remember what that's called? Ciliary body. Okay, excellent. And that's what produces your aqueous humor and what makes the fluid that fills the front of the eye. That's F. E is the white part, we should know, the sclera. Okay, and the sclera is white. It's covered by a transparent vascular layer called the conjunctiva. Then that over there, H. Any volunteers? It's basically the exit from the eye to the brain, the optic nerve or the disc, the optic nerve head. Then if we go to K, which doesn't show you very well, but it's meant to be showing you some jelly which fills the back of the eye, so in front of the retina, between the lens and the retina, the vitreous. And I is this little brownish spot where most of your photoreceptors are concentrated in the retina, your central vision or fixation, your macula, or the center is the fovea. And so you've got the retina lining the inside, then there's a vascular layer between that and the sclera. Any ideas? The choroid. Okay, so it's all kind of a continuous, the outside is all sclera and cornea, it's a protective collagenous layer that's there, that's meant to coat everything and cover everything and protect everything. It's obviously clear in front so that you can see and not clear elsewhere. And then the vascular layer, which is the choroid, is continuous with the ciliary body and the iris because it's all muscular, pigmented vascular tissue. Okay, and then the retina goes up to just behind the ciliary body and it lines the whole back of the eye, and that's got all your all your neurons. Okay. So that's just a bit of So I'm not going to teach you this because you guys know this better than I do, what the different systemic effects of pregnancy are. But this is obviously the basis as to why we see what we see in the eye during pregnancy, or why. So it's a combination of hormonal changes, metabolic changes, hematological, immunological, and cardiovascular. So if we're going to divide the way pregnancy affects the eye up, the best way to do is look at what physiological changes occur, what pathological changes occur, and what pregnancy does to pre-existing conditions. So this slide is quite busy, but I'm just going to leave it there for you to look at because it's a good summary of my next two slides. But it's basically the physiological or more innocuous changes that occur in the eye as a result of pregnancy and the more pathological conditions. And it's divided up into sort of different structures. So I'm going to start with the more physiological, benign kind of changes. Yes, sure. I'm going to get to most of them, but you're welcome to ask. Okay, sure. So we'll start with intraocular pressure. That's what IOP is. We use a lot of abbreviations in ophthalmology. Apologies for that. But generally what happens in pregnancy is that your intraocular pressure actually comes down by about 2 to 3 millimeters of mercury. Normal is between 10 and 22. So you'll often see a physiological reduction of about 2 to 3 millimeters. And that's just a case of you've got decreased venous episcleral venous pressure, and that aids or facilitates the drainage of the aqueous from the eye. Okay, so what that means, we'll talk about glaucoma, but it does mean that your glaucoma patients tend to remain quite stable during pregnancy. So the eyelids and the conjunctiva, here it's anything that affects the skin can also affect the eyelids. So the things like pigmentation, melasma, chloasma, although it's mostly cheeks and nose, forehead, it does affect the eyelids as well. And you obviously know that melasma, chloasma, pigmentation is dependent. There is some genetic predisposition. Certain skin types are more prone. UV light exposure obviously aggravates it, and the use of oral contraceptive pills also tend to induce it. So it's also hormone-based. Ptosis, you know what ptosis is? So it's a droopy lid, okay, usually an upper lid. And there it's more a case of hormonal changes. You do get a bit of tissue laxity, and it's usually on a mechanism that the aponeurosis or the attachment of the levator muscle is sometimes a little bit lax, and that usually reverses again. You also might get a degree of mechanical ptosis. If you've got a little bit of fluid retention or edema, you could have a little bit of lag or effect. Then granularity of conjunctival blood vessels. I can't say that I've ever really looked for this or seen it, but they just think that the drainage is a little bit poorer, so you can have blood vessels that look a little bit more granular or segmented. Then the cornea and refraction. So I don't know if I'm going to answer your question, Prof. Hall, but the most important thing is that patients will often complain of fluctuating vision and things during pregnancy, and it's mostly to do with corneal hydration. So what happens to the cornea is it actually becomes more hydrated than usual, which leads to a little bit of thickening, which changes its refractive index. So it ends up bending the light a little bit more and inducing a degree of refractive error. The curvature of the cornea can also change, and the sensitivity of the cornea. So if your patient's a contact lens wearer, they'll often become intolerant or more sensitive to their contact lenses during pregnancy. So they often go back onto glasses and things during pregnancy, and it's also a contraindication for you to go and refract them or make them a new pair of glasses during their pregnancy. You rather wait until 2 to 3 months postpartum for things to normalize again. And if your patients are considering LASIK or laser refractive surgery, it's a complete contraindication because their refraction or their tissue isn't stable during pregnancy, so you want to wait until they're postpartum in order to address that. And then there's also the same way the cornea hydrates, the lens hydrates, which means it thickens as well, and you get a bit of myopic shift, and you can lose the ability to accommodate slightly during pregnancy, all of which are transient and get better. But it's probably the most common visual complaint or complaint that patients would have during pregnancy. It's also the most common in any diabetic, not only in pregnancy, but because of fluctuating blood glucose levels, that determines the sort of osmotic gradient in the eye as well. So that determines whether the lens absorbs fluid or doesn't. So you get intermittent lens swelling with poorly controlled diabetics, and their lens swells and comes down, swells and comes down, and mostly lens in diabetics because it's more glucose pathway driven. But yeah, they usually complain, and then as the control tightens, they stabilize quite nicely. But also that intermittent swelling and unswelling is what leads to them developing earlier cataracts as well. Okay, and then tear production, which also goes to do with if you've got a dry, gritty eye and your tears are not a normal, if you're producing less and they're not a normal composition, you're also going to find that your contact lenses are going to feel less comfortable and stuff like that. Okay. So generally you want to wait until they're postpartum for things to normalize before you make them glasses or before you do any surgery on them. Otherwise your outcomes are going to be rather unpredictable. And then visual field here, enlargement of the pituitary gland. So it's normal, I was quite surprised to read that it's normal for the pituitary gland to enlarge as much as 30% during pregnancy. And that's probably mostly attributed to the production of prolactin. So they say that generally you won't experience a visual field defect from that enlargement of the pituitary gland unless you have an abnormal anatomical position of your chiasm. So we talk in neuro-ophthalmology terms about a chiasm being prefix or postfix. So instead of being right above the pituitary or right at the pituitary, it's slightly in front or slightly behind. In those instances, you might develop a visual field defect more commonly than if it was right in the middle, because you'd be compressing on one nerve or one tract as opposed to the chiasm. Okay, pathological changes in pregnancy. Now this is where probably the bulk of what we see or what's important comes in. So we've already spoken about ptosis. I'm not going to talk about it again. Most of the time it is reversible. Optic neuropathy, so these are an ischemic optic neuropathy usually, and that's because of the hypercoagulable state of pregnancy, and that's what we often get, an anterior ischemic optic neuropathy. And then if there's hypoperfusion, you can get a posterior ischemic optic neuropathy. So this is something that's well described in perioperative patients or patients with significant blood loss, long duration of general anesthesia, spinal surgery where blood pressures drop and there's hypovolemia. It's quite well described that you get hypoperfusion of the optic nerve and essentially an infarction. So this would be in your severe antepartum or postpartum hemorrhages or cases like that. With posterior ischemic optic neuropathy, almost zero. It's poor and profound. Anterior ischemic optic neuropathy, it's usually less profound because there's other circulation as well, and there is a degree of improvement. Okay, and then idiopathic intracranial hypertension. So you know that that's associated with patients who have a sudden increase in their body mass index or weight, and pregnancy is a condition where you do gain a significant amount of weight over a shortish period of time. So your patients who are at risk might actually present during pregnancy, or pregnancy may be their aggravating factor. So these are patients who usually, the predominant symptom is headache. More than 80-90% of patients have headache, and then disc swelling. And it's not always bilateral. It's mostly, but it can be unilateral, very asymmetrical. And then there's also about a 20% chance of them having a sixth cranial nerve palsy as a false localizing sign due to the raised intracranial pressure. So usually you'd see a patient that have headaches, disc swellings, and the headaches are typical of raised intracranial pressure. So the first line investigation is always to do neuroimaging to exclude a mass lesion. And should your CT scan be absolutely normal, your next investigation is a lumbar puncture with an opening pressure. So that's always done in the left lateral position in order to measure the CSF pressure. Okay. The tricky thing with idiopathic intracranial hypertension in pregnancy is how to manage it. Because number one, the most effective way to manage it long term is to reduce your body weight by 10%, because then it's cured. But you cannot do that in pregnancy, for one. Secondly, the drugs that we use to treat it, like carbonic anhydrase inhibitors, are teratogenic, particularly in the first trimesters, so you can't really use them. And then topiramate is also another agent that's used very widely in idiopathic intracranial hypertension, which is also thought to be teratogenic. I think it's meant to have significant defects have been described. So managing it is very difficult. Okay, then I'm not sure if you've ever heard of a Purchase-like retinopathy, but it's usually a compressive thing. So it's not quite a Valsalva, but it's as a result of significant compression to the trunk or the head, which could occur during labor, and that results in sort of retinal whitening or infarction and some hemorrhages around the disc. there is an image coming up, so I'll remind you of that. Not very common, but it is something that we do see from time to time. Gestational diabetes comes in here as an effect of pregnancy on the eye. We're going to talk about the effect of pregnancy on existing disease and normal diabetic retinopathy again in the next slide. But gestational diabetes, just remember, it resolves, most of the time it resolves postpartum, and those patients are not at any additional risk of developing diabetic retinopathy because they don't have the disease for a prolonged period of time. Pregnancy-induced hypertension, here you'll know much more about this than me, but preeclampsia, eclampsia, and I'm not sure, it's the first time I've seen it referred to as pregnancy-aggravated hypertension. And this, they seem to think, is more chronic hypertension that gets aggravated in pregnancy.
Pregnancy-associated?
Well,
pregnancy-associated hypertension is a new word for gestational
hypertension. Okay, so that's without the proteinuria component.
Hypertension, so it's not chronic hypertension.
Okay. So then the chronic hypertension worsened in pregnancy is a different group of patients. Okay, and here just to remember that what you see in the retina often mirrors what you're seeing in the placenta because it's a vascular structure. And I'll go through the specific changes of, it's the same as hypertensive retinopathy in a non-pregnant patient. The signs are the same, but it's more accelerated because it's often more severe and over a shorter period of time. So it's not like seeing a 65-year-old who's been hypertensive for 10 years who's developed the changes. It's a more accelerated or the old malignant hypertension type signs. But the signs are the same. And then we do, in pregnancy, see particularly a hypertensive choroidopathy, which you almost exclusively see in the pregnancy setting. I'm going to go through diabetes and hypertension in a little bit more detail in a second. And then just to remember that from cerebral edema in eclamptic or severe pre-eclamptic patients, you can get cortical blindness. So you can have a completely normal eye, retina looks normal, disc looks healthy, everything looks normal, but the patient has blindness, normal reactive pupil, so it's not an optic nerve or pathway issue, it's something right at the back. And that is usually from cerebral edema, but is most likely transient and does resolve again. It's quite frightening for the patients, though. Yeah.
So could you get that just with press? So
Oh, with
bleed or hemorrhage in the occipital area?
Yeah, you can get that with edema, with any vasogenic edema and stuff in that area. Central serous chorioretinopathy, which probably sounds like a big word, but it's probably something that we do see reasonably commonly in pregnancy. And they're usually healthy patients. What central serous chorioretinopathy outside of pregnancy looks like is it's generally, we see it in type A personality people who are highly functional, very stressed, and it's usually cortisol driven, so either endogenous or exogenous, and they come with a mild impairment of their vision, and what happens is that they've got a bit of fluid under their macula, and it's this sort of increased vascular permeability that's cortisol driven in that area, and it's a localized bit of effusion, and it resolves spontaneously, and they can have recurrences. So the reason it's thought to be more, or why pregnancy tends to induce recurrences, or that it tends to occur more often in pregnancy, is that there are a lot of hormonal changes. There's quite a high cortisol level during pregnancy, and there are lots of prostaglandins around to alter vascular permeability as well. Okay. It's something that you wouldn't really see when we see the patients. We can vaguely see that their vision, instead of being 6.6, will be maybe 6.12, 6.18. It's seldom worse than that. And then on examination, you'd need a binocular way of looking at it. So a normal ophthalmoscope, you're only always using one eye, so you've got no depth perception. But we get the impression of a slight elevation at the macula, and then fortunately we've got fancy machines that can show us if it really is elevated and if there's fluid there. And then occlusive vascular disorders, and these tend to occur in your conditions like TTP, and if there's DIC or antiphospholipid antibody syndromes or embolisms. And it's a whole spectrum of arterial or venous occlusions, and they can occur anywhere from the retina all the way back to the brain, and obviously also affecting the cranial nerves or the motor nerves, ocular motor nerves. And then I wasn't all that aware of this, but I know that there's talk about a lot of melanomas being somewhat hormone responsive, and that cutaneous melanomas can worsen during pregnancy. So we do see uveal melanomas, which are in the choroid or the iris or the ciliary body, but they're apparently less responsive to hormones than the cutaneous. I don't know if you do see much.
We don't really challenge
by that. I think our patient population is also not the risk profile for melanocytic tumors.
But just looking at your list, I mean, the one that tickles all of us, because I'm sure you every medical discipline is aware of the epidemic of obesity.
Mm-hmm.
And we see more patients, I can recall 2 in the last year, that were known as benign intracranial hypertension. But the idiopathic one, well, that's going to challenge us, because headache in pregnancy is...
Yes, exactly. That's one of the... Well, I mean, that's...
and we're going to see a lot more ladies that have accelerated weight gain, say, prior to pregnancy, and also pick up excessive weight gain.
So the terminology around idiopathic intracranial hypertension has changed quite a lot. It used to be called pseudotumor cerebri. It's changed its name a number of times. Essentially, it is... Pseudotumor cerebri now implies that there's a secondary cause. So it implies that you've had exposure to a lot of vitamin A derivatives, or there are a number of drugs that are implicated in basically benign intracranial hypertension or pseudotumor cerebri. So vitamin A derivatives, a lot of antibiotics, doxycycline, nalidixic acid. It's an extensive list. Then there's also a group where they've found that there are venous sinus stenosis of the dural venous sinuses, a stenosis or a thrombosis, and that's also considered to have a secondary cause. Whereas this idiopathic intracranial hypertension group is the group where there isn't necessarily a clear precipitant. But the terminology seems to change every couple of years.
There are 1 or 2 drugs that we can use, I think, from the second trimester on. But previously, a long time ago, I think it was treated with
serial lumbar punctures.
Do you think we could resort to that if we can see what it's going to lower efficacy?
The neurologists have definitely steered away from it. They do it as a temporizing sort of measure, but long-term control is usually medical, and that's where topiramate is a great agent outside of pregnancy, because it elevates the mood slightly. It's great for headache. It's also an appetite suppressant, so it helps them curb their appetite and improve the chances of them being able to lose their weight. We tend to, as ophthalmologists, divide IIH into predominantly 2 groups: a group where the headache predominates, and a group where the headache is there, but they've got significant disc swelling that's causing visual loss. Because often we'll see them and they've got swollen discs, but they've got 6/6 vision with no visual field defect, and they're completely asymptomatic from a visual point of view. But occasionally we see them and they've had disc swelling for so long, and they're starting to develop secondary optic atrophy or developing permanent loss of vision. So the reason we divide it like that is that the management differs. So if you can't manage them medically, the management is surgical both ways. If headache predominates, they usually get a lumbar peritoneal shunt to decrease the CSF pressure. And if the visual symptoms predominate, we do an optic nerve fenestration. So we basically make a couple of pores or slits in the optic nerve sheath to allow the fluid to drain there. And interestingly, with optic nerve fenestrations, they've actually shown that unilateral is as effective as bilateral. So it's not a procedure without risks, because you're very close to a lot of dangerous structures, but you only need to fenestrate one eye to get an effect on the other eye as well. But it is something we see fairly often. I can almost say we have a patient like this once a week that's admitted and worked up. And our obesity levels they're not getting any better. So I think carbonic anhydrase are all right from the second trimester, or so all right from second trimester onwards.
That's the information we have, that we always go back and check.
Okay. Okay, so then effects of pregnancy on the eye. So these are now the pre-existing conditions, ocular and non-ocular. So diabetic retinopathy is obviously the one that we're probably most aware of and the one that we're all sensitized to. And pregnancy is an independent risk factor for progression of your diabetes. There's no doubt about that. So the main things influencing it are the duration. It's the same thing for diabetes outside pregnancy. Duration of diabetes is what's important. Your glycemic control, so your baseline HbA1cs, and your degree of diabetic retinopathy at conception. So how much disease you already have at the time of falling pregnant, and then any coexisting hypertension. And I've got one patient that still haunts me who had quite severe diabetic retinopathy early in pregnancy, and we were umming and ahhing about whether she needed to be lasered. Saw her 2 weeks later, and she'd actually regressed. Everything looked fantastic. So we thought, okay, well, we can sit back a bit. Saw her a month later, but she'd moved into sort of late second trimester, and she developed some really bad hypertension. And she'd gone from being sort of not needing treatment to one eye being too late to treat almost. So the effect of hypertension is remarkable. And I mean, you'll know that cotton wool spots are a sign of diabetic retinopathy, and it's what you're taught, but in ophthalmology we see cotton wool spots really in isolated diabetic retinopathy. For us, they're a better indication of hypertension. Okay. I'm going to go into much more detail about that, but glaucoma, we spoke about the fact that generally it's improved. Medical therapy in glaucoma is obviously difficult because most of your agents are not proven safe, so we use beta blockers, alpha agonists, and prostaglandin analogs. All of them problematic. Beta blockers, timolol is probably the one that's been thought to be reasonably safe. Because all the agents are topical, hopefully, we try and limit systemic absorption by telling patients to occlude the punctum after installing the drop so that it doesn't drain via the nasolacrimal duct into the nose, because that's where it gets absorbed systemically. So we try and get them to do a punctal occlusion for 5 to 10 minutes after putting the drop in, and that further limits any systemic exposure. But from the evidence that I've seen, timolol is thought to be okay. Bromonidine is also maybe acceptable to a degree, and then the prostaglandin analogs, there's not much evidence to support that they're safe. The problem is there's not much evidence for any of it. Intracranial tumors, we've spoken about the pituitary adenoma. So if your patient does have an existing adenoma, either diagnosed or undiagnosed, with the enlargement of pregnancy, that can pose significant problems. And then obviously apoplexy can cause. So not something that you see often, but just to remember that if your patient is pregnant and has a sudden loss of vision or a sudden onset of visual field defect associated with headache, and often an ophthalmoplegia, because often the cavernous sinus and the oculomotor nerves are also involved, then you need to remember this entity. Meningiomas, something we see a lot of in middle-aged women, often paracellar or sphenoid wings, so they often have quite a lot of hyperostosis, but because there are estrogen and progesterone receptors, they can enlarge during pregnancy. Graves' disease, and this is another one that's tricky because your symptoms of pregnancy and your symptoms of thyroid or hypothyroidism also overlap to a large degree. So you're not necessarily going to pick it up, but generally Graves' disease is worse in your first trimester and then starts improving again in your second and third trimester, with the risk of postpartum flare-ups and things. And then again, your treatment options are reasonably limited. In the sense that you can use the the medical agents reasonably safely, but you can't use any radioactive iodine or anything like that. That all has to be delayed until postpartum.
Graves' disease common in our clinic because of the age group that it occurs in. Most of them are existing diagnoses, and one lady that troubled me in the last year was a lady that had marked unilateral exophthalmos, and I was worried that that wasn't really just Graves' disease. But speaking to your department, that's
unfortunately it's sort of unexpected for a systemic disease to be so asymmetrical, but it can be. So we're always taught that the most common cause of a bilateral proptosis is thyroid eye disease, and the most common cause of a unilateral proptosis is still thyroid eye disease. So it can be very asymmetrical. You obviously know the signs. They usually have the thyroid stare. They've got a lot of increased fluid in the fluid and glycosaminoglycans in the muscles, the extraocular muscles, and the periocular tissue. So a bit of a bulky retrobulbar area. So the orbit's full of tissue and fluid. So the eye tends to bulge. At the same time, they get lid retraction, which then makes that bulge or stare seem even worse because the lids pull back and make the eye seem like it's bulging even more. And
do you ever have to do surgery to remove those masses? Or,
no. So the way thyroid eye disease works for us, there's the inflammatory phase, which is the phase when you get the antibody-mediated swelling and increased tissue and all the inflammation. They're often quite red, inflamed sort of eyes. So that's the active or inflammatory component, and then that lasts maybe 2, 3, 4 years. Then it tends to burn out. And we don't operate while it's active. We only operate when it's... So we've got to get the patient through that 3-4 year period, and then later you go and do any corrective surgery. Unless the optic nerve is threatened, because you do sometimes have these muscles that are all swollen, and obviously at the optic canal or optic apex, you've got a tiny foramina through the skull, and if your nerve now has enlarged muscles sandwiching it, you get a dysthyroid optic neuropathy or compressive neuropathy. In those cases, we often do medical decompressions with steroids, intravenous steroids, or you then go and do orbitotomies. You basically go and break their orbital floor, their medial wall, and you just give the tissue space to sort of prolapse into.
And the surgery,
So the,
for diplopia, you don't do it for cosmesis?
No, we do it for cosmesis as well. So the only thing, the surgery, when you do it, the main components that you then address surgically are if there's diplopia, so if there's muscle that's now become fibrotic and can't move the way it used to because of the fibrosis, which is secondary to the inflammation, then you go and move the muscles. And then the lids, you can go and do something for the retraction. You can basically go and release some of the muscle fibers to allow the lid to close a little bit better. The most common muscle involved is usually the inferior rectus, and that tends to, one of the hallmarks for us is we need to always do the muscle surgery first before you do the lid surgery, because sometimes what happens is as soon as you release the muscle, the lid actually drops a little bit because it's overfiring, because the way your ocular muscles work is they're antagonists. So if your inferior rectus is working really hard to move, your superior rectus is kind of also overfiring, and that can give you, and superior rectus and your levator, which is your muscle that elevates your lid, have a common nerve supply and a common sort of aponeurosis. So often the moment you relax the inferior rectus, the rest relaxes as well. So it always has to be done in a certain sequence, otherwise you'll end up chasing your tail or not knowing what you're going to get. Okay, but yeah, so there's orbital surgery to try and relieve the proptosis or pressure on the nerve, and then there's muscle surgery to improve the diplopia, and then the lid surgery, which is often cosmetic, and often they've got lag ophthalmos, so they can't actually close the lid properly, and they get corneal ulcerations and things because there's exposure. Particularly if, I don't know if you know, but when you close your eyes, you've got a reflex that causes your eye to drift upwards. But if your inferior rectus is stiff, your eye can't get up. So it's then more prone to exposure as well. Okay.
So what do we do for IT during the night?
Taping.
Just
We usually tell them to tape. They usually also put a lanolin ointment, so, or even chloramphenicol ointment to a degree, but basically just an ointment into the fissure or into the whole conjunctival sac, and taping is probably the most effective way to prevent exposure.
that particular patient's eye actually, either I got used to or it improved during pregnancy. If they don't get improved, so
Okay. Usually they're the best. The patient always knows if it's improved because they're quite bothered by their appearance in thyroid eye disease. Okay, and then conditions that you don't really need to know anything about, but inflammatory conditions, posterior scleritis and Wacke-Harada, they're basically just inflammatory conditions, and in pregnancy they can often be aggravated or recur, and then there is one particular inflammatory condition that tends to regress or resolve in pregnancy. It's a condition, it's an autoimmune condition that tends to cause vitiligo, hearing loss, and some pigmentary changes in the retina and choroid. Then immunological diseases, things like rheumatoid arthritis, sarcoid, or your spondyloarthropathies are also thought to probably improve during pregnancy because of your endogenous hormones and cortisol and steroids and things around. But then the important thing to remember is once you withdraw all of those postpartum, there's a high risk of recurrences and flare-ups. Okay, so that was a lot of information. So now we're going to get on the more interactive part. Okay, how can I or how do I examine the eye? So you can hopefully remember what that little thing is. Okay, that's a direct ophthalmoscope. So the advantage with a direct ophthalmoscope is it's portable, it's reasonably cheap, and generally you've all been exposed to one at medical school. The view you get with it, unfortunately, is generally quite limited. Your field of view is quite small, but it is magnified. So what you're seeing is at quite a high magnification. The downside is you're only using one eye. So you can't really, you've got no binocularity, no depth perception or stereopsis. You can't see whether anything's elevated or kind of located, really, whether it's in front of the retina or behind or anything like that. But it's easily available. Obviously, it works better through a dilated pupil. Okay. Does anyone still do fundoscopy? Okay. Has anyone seen a panoptic ophthalmoscope? Okay. So essentially, it's the same sort of thing, but it's got some better optics, and it's got a sort of tube. So the patient's eye is now essentially in the dark, which allows the pupil to dilate a little bit more, allows you a much wider field of view. And we've got some in our clinics. The students really enjoy using them. I bumped into a lady at a meeting, at a Discovery Foundation meeting last year, who is a family physician at a number of clinics in Neisner, Georgia area. And she said she discovered this ophthalmoscope about 3-4 years ago, and it's changed her life. So it's something worth looking at. It's not that expensive. It's got an attachment that basically attaches to that same handle. Okay. We've got both of these in our clinic. So if anyone, and I'm not saying that we need to teach you to do ophthalmoscopy, but if you did want to practice your skills or actually just go through a quick course on how to do it, please feel free to contact me and I'll spend some time with you. We've got patients who are dilated every day. They're candidates waiting to be looked at. So if you did want to practice, you're welcome. But what we can offer you is something even better. So this is a smartphone, an iPhone with an attachment, and there's a lens basically in that ring. The contraption is, or the attachment is 3D printed, so I think it costs about 800-900 rand to make and sell. The lens is commercially available. Thanks to the stronger rand at the moment, it's around about 3,500 rand for a lens. So that whole combination obviously is reasonably expensive, but that's Will Mappin, one of our registrars. That's him, and that's his eye. So you can see you get probably a much better view than you actually get with a normal direct ophthalmoscope. just to remember that when we're using a condensing lens like this, the image is always inverted. So left, right, switches, and up and down. So that's his macula there, which is actually usually temporal, and that's inferior and that's superior. Okay.
You don't get TV when you're checking a person's eye.
Well, we check people's eyes. We're at that kind of close proximity to patients daily, unfortunately. Okay, but this is just, the only reason I mention this is you might not always be in this department where you can send a patient to us. So what happens and how we deal with a lot of referrals to our department at the moment, not necessarily with fundus photos, but with other conditions, is via a smartphone app. And you'll get hold of the registrar on call and you'll get a response within 15 minutes. So whether a patient needs an urgent, a non-urgent, or an elective kind of referral, what essentially you could have one day is if you had a contraption like this and could take photos, you could send them to someone who could tell you what retinopathy was present or if any and how soon this patient needs to see you for another photo. And that contraption of 5,000-6,000 Rand or 5,000 Rand is a lot cheaper than a commercially available fundus camera, which will cost you between 150 and 200,000 Rand.
Is that looking at the same percentage of the retina as an ophthalmoscope?
That's seeing a lot more than an ophthalmoscope. So if you looked at a direct ophthalmoscope, you can usually see the disc and maybe one disc diameter around the disc. And then you have to move around then you have to follow a vessel to see a bit further and a bit further and a bit further. This is taken with a 20 diopter lens. We've since started using a 28 diopter lens, which gives you a smaller, a less magnified image, but a wider field of view. Okay, so this is the last slide before we go into the quiz. And this is just to recap the signs of diabetic and hypertensive retinopathy. So just diabetic retinopathy, you all know that you see hemorrhages. Hemorrhages, we tend to try and give descriptive kind of descriptions. So they're either dot and blot. So in other words, the hemorrhages should look round or roundish. And then flame or splinter-shaped hemorrhages where they look like a flame or a splinter. So they're usually linear or streaky. And then vitreous hemorrhages, which you can usually get the impression are in front of the retina or impairing your view of the retina because you can't see through them. Cotton wool spots, as the name suggests, a little bit fluffy. They're white. They're in the superficial retina. They're not very well circumscribed. Exudates, which are actually just cholesterol lipid that's leaked out of blood vessels. So it's refractile. It's quite shimmery. And it's yellow. And it's very discrete because it's a cholesterol salt or particle. And then blood vessel changes, we get beading and microaneurysms, and then neovascularization, which is basically when your retina is so ischemic that it's sending out vascular endothelial growth factor to try and get your retina to get more blood supply. It starts making abnormal new blood vessels. Okay, so that becomes your proliferative diabetic retinopathy. So then we divide retinopathy and diabetes into the retina as a whole and then the macula, which is your central vision. So there's either no retinopathy, or from medical school days you probably remember background and pre-proliferative. We now just group those together as non-proliferative and proliferative. So nothing is nothing. Non-proliferative is pretty much all of those signs to varying degrees without the neovascularization. Proliferative is as soon as you have neovascularization. And then maculopathy is when your retinopathy is, or looking at the macula specifically, and there it's either exudative, so if you're seeing lots of exudates or fluid that's leaked out and macular edema, and then or ischemic maculopathy, which is you can have a suspicion that there's ischemic maculopathy if your patient sees really poorly, but you can't see much evidence of diabetic retinopathy. You don't see lots of exudates or hemorrhages. But the only way to know for sure, because you don't know what an ischemic retina looks like compared to a normal retina without doing an angiogram. Okay. Hypertensive retinopathy, we divide into retinopathy and choroidopathy, so the retina being the retina, and the choroid being the vascular layer underneath the retina or outside the retina. So just like in chronic hypertensive, their blood vessel changes. There's arteriolar narrowing and venous congestion. So when veins are congested, they become more tortuous, or their diameter becomes larger. Hemorrhages here with hypertensive, we see mostly the flame or splinter-shaped hemorrhages, cottonwool spots. So very similar sort of size, and then disc swelling and exudative retinal detachments. Your choroidopathy is usually your exudative detachments, and then choroidal infarcts and necrosis from those choroidal infarcts. Any questions?
Can I just ask, why does diabetic retinopathy worsen in pregnancy? Does it, once you've already got established proliferative?
Yes, so they say unless you have, generally the guidelines for screening, which I'll remind you about at the end, is generally if at the point of conception you have either severe non-proliferative or proliferative, then you are at risk of progressing. Generally, if you have the milder forms, you're not at significant risk of progressing. So it's basically worsening of the ischemia that you already have. So you've got changes that have taken years to occur, but now you're obviously at a more critical. You've got less to lose before you're going to start proliferating. And pregnancy is often what tips you over that, and then often the hypertension along with that.
Using the retina as a screening tool for preeclampsia, first trimester, long before the symptoms. I've seen some research on that.
I can't say I know much about that. I can't say I've seen much on that. Do you know what they look at specifically?
I'd like to know. You're taking a picture of the patient at the lowest clinic and sending it to someone that can screen that patient on the basis of what they see and select that patient as a high-risk patient for preeclampsia might work for us.
Yeah, my experience with preeclampsia in the eye is that you don't really see this until late. That they've got established preeclampsia at the point when you're starting to see the visual loss and the exudative detachments and things like that. So I don't know.
That's also got to do with the referral bias, because we're referring.
Yes, you're obviously referring that.
But I'm not aware of that kind of stuff.
Yeah, I'll have to look into that. I'll happily get back to you, but I haven't seen any sort of early signs that are. I can't think of any early detectable signs.
Just as you said, it is more or less the same as the placenta, so if there's some
Yes.
you should be able to see it.
I suppose you'd look at vessel changes and things like that. Yeah, that would be. Thank you. I'll happily look into that. Okay, are we ready? Okay, so an easy one to start with. Okay, which lid? Okay, good. Just checking. Okay. Unfortunately, there's an arrow to show you which eye is abnormal, but there are ways to tell you. So, just what can you see? Okay, so that pupil's a bit smaller than that pupil, and maybe that eyelid's a little bit lower than that one. Okay, so whenever you've got pupils of different sizes, our first thing to do is to check what their normal physiological response is, because you don't know which pupil's abnormal here. Is that one abnormal or is that one abnormal? So you want to put them in bright light, and you want to see if they then both constrict, because then this one was probably the abnormal one because it wasn't constricted before, and you want to put them both in dim light, and if this one doesn't dilate, it'll just give you an idea of which one's abnormal. So can you think of any conditions where you have a small pupil and a very mild ptosis? Horner syndrome. Excellent. Okay, so that's parasympathetic. So with your eyelid, you've got a skeletal muscle, your levator, but you've also got a parasympathetically innervated muscle that does a small proportion of the work. So usually it only elevates the lid about 5% of the whole. So that's why you're not seeing a significant ptosis like the other patient, because the skeletal muscle here is still working. It's just the Muller's muscle, the parasympathetic or smooth muscle, that isn't. And your pupil is also sympathetically innervated, so you've got a smaller pupil there because of a Horner syndrome. So it's a sympathetic problem. It's usually a lesion somewhere along the sympathetic chain. You get pregangliotic, postgangliotic, so it can really be anywhere from the thorax up, so pancreas tumors, neck lesions, carotid aneurysms, and then all the way up to the ciliary ganglion, and from the ciliary ganglion the fibers generally travel with the third cranial nerve to your... Okay, so, but there is a slightly high incidence of Horner syndrome in pregnancies. They say it's not actually in pregnancy, it's during your epidural anesthesias. And I think it's if you get a little bit of a high epidural and you get a little bit of changes there. So it's usually transient, and as soon as your epidural's out or has worn off, your Horner syndrome should go away. Okay. Should be fairly obvious what where the problem is, what it is. Any volunteers? Okay, so that's a hemorrhage, definitely. It's a subconjunctival hemorrhage. So the conjunctiva is basically transparent but vascular, overlying the sclera. So there's a potential space or space between it. And you can quite easily get a conjunctival hemorrhage. It can happen spontaneously if you're slightly hypertensive or if you Valsalva. And there are a few times during pregnancy where that might happen. Okay. Nothing to be concerned. It's quite alarming for patients. But there really is nothing you can do to make it go away any faster. You just got to reassure them that it's on the outside of the eye. It doesn't affect the vision, and it might look bad, but it has no consequences, and it will get better. It usually takes 2 to 3 weeks to resolve, depending on how large it is.
People doesn't look like concentric, but is that just the photo?
I think it might just be the photo. I think that the pupil actually goes there. I think there's just a little rough of iris running there that sort of gives you the false idea that that's the margin. If you did see an irregular pupil in this, then trauma would be high up on your list. Patients who've taken a bump to the eye, because they often get little tears of the iris sphincter at the edge there. Anyone? Okay, it's a trick question. This is a completely normal fundus. Okay. So the optic nerve, or the optic disc, optic nerve head, you should be able to see this is a normal kind of pinky orange one with a slightly paler cup. So we always look at the disc, and you always want to look at the contour and the color and a few things at the disc. The contour is that you can pretty much draw a circle around it. Because if there's anywhere where you can't see exactly where it starts and ends, it's usually an indication that there's some swelling. Okay. And then you usually have your blood vessels that branch off from there, and then that's your macula, which is slightly more brown or darker. Okay, so you don't have to tell me what the condition is, but just anyone want to describe what these sort of yellow areas are? Yeah, so those are hard exudates or lipid. So that's leaked out and it's sitting in the superficial retinal layers, and it's quite a crystalline sort of cholesterol. You can see it's yellow. It's quite shiny. You get a bit of a reflex back off it, and it's very well circumscribed. You can see where it starts and finishes. Okay, so those are all hard exudates, and then there are a number of little hemorrhages. Most of those are little dot hemorrhages, and maybe a few sort of dot and blot hemorrhages. Okay, so this is a diabetic, and those exudates are around the macula, so you could say that there was some exudative maculopathy, and you would say that there are some dot and blot hemorrhages and exudates. Okay. So here you can see the hemorrhages look a little bit different. You appreciate that they're a little bit more linear, they're kind of streaky, more almost like a flame-shaped hemorrhage or a splinter hemorrhage. and those are in the more superficial retina, the retinal nerve fiber layer, which is the most superficial layer of the retina. They tend to run sort of in the nerve fibers, so they look like little splinters. Okay, so that we also see in diabetes and hypertension. This particular patient had a valsalva and got a little hemorrhage from valsalvaing. Okay. Okay, here I think just to show you again, that still looks like exudate, and then these are microaneurysms, which are little dot hemorrhages. And it's usually those microaneurysms that leak, and that's where the lipid or the exudate, the cholesterol, comes from. Can you just kind of, I don't know if you can see this vessel down here, this vein, a little bit sort of, a little bit tortuous, almost convoluted. It's a little bit. So that usually happens in diabetes and hypertension, that you just have a little bit of venous tortuosity. And we sometimes see venous beading, so a more extreme point of this is where you can almost see like a string of beads. So it's a bubble and then it narrows, and a bubble and it narrows. Okay. Yes, I don't have too many more. This is just a hemorrhage. Hopefully you might appreciate that this is in front of the retina, but generally when you see a subhyaloid or a pre-retinal hemorrhage, you can often see a almost fluid level. And it's the reason that you've got vitreous with a membrane around it that's quite adherent to the retina, and it sort of dissects that space open, but it's a cavity, so you'll almost get a fluid level with those hemorrhages. They often say it looks like a little boat or a wedge. Okay, anyone see the obvious pathology there? Okay, so you can see those are your arteries and a little bit of sort of silver wiring, and that happens when you get thickening of the artery wall from hypertension or arteriosclerosis. So you don't see the blood column throughout. Veins have a thinner wall, they don't thicken from arteriosclerosis, so you don't see it so much in the veins. And then all of these little things here are actually new vessels. Okay. And then just an example here, can you appreciate a difference between those spots and those spots? These are slightly more discrete in yellow. These are slightly less well-defined and more white. So these are actually cotton wool spots. And cotton wool spots are small little retinal infarcts. So they're less well circumscribed because the margin is not very clear. Okay. That just is we call that a macular star because it looks like a star. Okay, and that we see in hypertensives, very, very common. So this is an accelerated or malignant hypertension patient. You should be able to see that the edge of that disc is not as clear as it should be. And there was fluid and exudate. That's now what happens is as the exudate or the exudative detachment resolves, the fluid goes away, but whatever cholesterol tracks towards the macula. And it leaves a star pattern. Okay. That's to try and show you an exudative retinal detachment. So you can see the retina is bulging, and there's a whole lot of fluid behind the retina. So you do see that in hypertensives. Here, these are not very good slides, but in not that you would ever diagnose hypertensive choroidopathy, but you get these little deeper white spots, which are actually choroidal infarcts. And after the choroidal infarcts, you get necrosis along the choroidal vessels, which you can't usually see, but you get these streaks showing you where the choroidal vessels were. Okay, that's quite profound. If you see that, that's a central retinal vein occlusion. And it's a whole lot of these splinter or flame-shaped hemorrhages and a lot of cotton wool spots and a bit of a swollen disc. The opposite of a vein occlusion is an artery occlusion. And that's where you get pallor and a so-called cherry red spot at the macula. Okay, so your patients that get arterial occlusions are your antiphospholipids, patients who have arterial risks of arterial emboli or thrombi. Okay, and then this is a purchase, which is a compressive lesion on the trunk or head, where you then get choroidal ischemia or infarcts and hemorrhages in the retina. Fortunately, the prognosis for this is actually not that poor. Okay. So this is an IIH patient, an idiopathic intracranial hypertension patient, and hopefully you can see that both of those discs look swollen. And I think this is just a diabetic again with some exudate. And the very last one is a patient with a pituitary adenoma. Okay. So just to recap, visual disturbances in pregnancy they're very common because of a lot of the refractive changes, the changes in the swelling and the composition of the cornea and the lens particularly, but they're mostly reversible. So they'll resolve again postpartum. So nothing to be aware of. Obviously, the most alarming things to be concerned about are pituitary apoplexy, which is rare, but it's headache associated with ophthalmoplegia and a visual field defect. And the visual field defect is usually a bitemporal defect, whether it's the whole half or just the superior half, but on the temporal sides. Then with diabetes, glucose and blood pressure control, ideally preconception is ideal, but we don't really get much experience with that. And ophthalmic examinations are obviously important in those cases. And then important to remember that the effect on the pregnancy on the retinal vasculature, a lot of the changes are reversible, but there are a proportion that are irreversible. So you've got to try and manage them as best possible. And then to remember, if you can, phone a friend, and that's what we're there for. So I know that hopefully we've got a reasonably open line of communication and referral system between you guys and us. But if you don't have access to that, mobile phone apps like Vula can help you in that sense. So just the screening guidelines before pregnancy, ideally you want to see a patient to check if they've got, this is a diabetic, pre-existing diabetes. You ideally want to see them before they're pregnant to see what level of retinopathy they have, or early in the first trimester. Once you've seen them in the first trimester, your follow-up is going to depend on what you see at that point. If they have no retinopathy, the chance of them developing any is rare, but the ones who have significant retinopathy, they're the ones at risk of developing sight-threatening progression. So I feel like I've tried to cover too much, but I hope you've learned something.
Thank you very much. Thank you very much, Robin. We do have a good open relationship with your department, but seeing you here, I think, just opens it up further. We've had the chance to interact with Robin. Are there any burning questions? Because otherwise we're going to I'll see Robin out, and then I'll hand over to him further. But just again, thank you very much.
Yeah, and I'd be very interested to look into that because I think it's something, that we could, looking for signs something that we could definitely do some research on if we could see
one of the interesting things to me is not eyes of humans, but I spend a lot of time photographing the eyes of birds. And that's very interesting because you can sometimes sex birds by the shape of their pupils. And in the deep diving, ones that dive to 200 meters or so in dark waters, their pupils have to expand so much that when they constrict, they actually get squid. That's called into a kind of a squid. So every time you go to the binoculars and you're looking for a secret cormorant and penguins, they're very good.
There are a few sort of physiological differences between male and female pupils and actually your eye apertures, your blink rates, a few things like that as well.
I'll hand over to you. I'm just going to see Robin.
Thanks.
I'm just